everyone, and welcome back to another enlightening episode of MedSynapse podcast series. I'm your host, Shah, and today we are diving into the topic of vertigo. Do you know that vertigo is more than just feeling dizzy? It can be a sign of underlying neurological issues that require careful evaluation and management. And to help us better understand vertigo, its causes, and the latest treatment options, we have with us Dr. Sreenivas Meenakshisundaram, an accomplished neurologist with over a decade of experience in this field. Dr. Srinivas has worked with prestigious institutions in London, and he specializes in areas such as deep brain stimulation, LCIG infusion, and the management of neuro-otological disorders. His extensive experience and numerous accolades, including the TISA Neurology Award, make him the perfect example to guide us through this complex topic today. So, thank you for joining Dr. Srinivas, and it is a pleasure for us to have you here.
Thank you, Nisha. Thank you for having me on the podcast.
Thank you. So let's just delve right into our topic, doctor. So could you explain what exactly vertigo is? And it can be misunderstood from with dizziness. So what is the difference between the dizziness and vertigo, and is it the same? And what are the different types of vertigo that healthcare professionals should be aware of?
So unfortunately, when we talk about healthcare professionals, vertigo is used as a diagnosis rather than a symptom. What you need to understand is vertigo is not a disease in itself. It is a symptom. It's a symptom of feeling of motion when there is no actual movement. That's the best way to describe it. So if you can feel that the room is spinning around you, you feel like you're suddenly moving to one side, you're moving to somewhere, your vision is changing. Sometimes the people say, I am spinning, but the room is not spinning. My head alone is spinning, or the room is spinning in front, the world is spinning in front of me. All these are what we call vertigo. It's basically a sensation of movement without actual movement. Whereas dizziness, it's a very, very non-specific symptom. It just feels unsteady. So what we say is something causing imbalance. So anything can cause dizziness. If you feel lightheaded, if you've not had food for some time, people can call it as dizziness. You can feel like I'm feeling giddy or I'm feeling dizzy. The loss of blood pressure can make you feel like that. Low blood sugars can make you feel like that. If you're very tired, you can feel tired. You can feel dizzy. So it's unfortunately, vertigo is, the best way to say is vertigo is dizziness. All vertigo can be dizziness, but not all dizziness is vertigo. So it is very important to differentiate between these two symptoms. Because when you say vertigo, you're talking about a specific involvement in the brain and the balance system. So when they are affected, you get vertigo. There are very specific structures in the brain and the neuro-otological structures, which the inner ear and the balance system, which can cause vertigo.
Yes, I think that was a very clear explanation and distinguishing points between the dizziness and vertigo. And thank you for breaking down it for us. Now that we have seen the difference and understood the difference between vertigo and what exactly vertigo is, so also could you walk us through the basic bedside examination needed for a patient presenting with vertigo?
So the most important question when somebody comes in with a vertigo is establishing what is going on. What is the cause of the vertigo? So first things first, we always try to see, is this a central cause? Basically, is the brain involved, or is the peripheral cause? A peripheral being the peripheral otological structures, which is basically your inner ear and the connections from it, your ventricle, cycle, semicircular canals, and all of that. The differentiation between these two is what the basic bedside examination is geared towards. We talk about the HINT exam. So it's a very well known acronym, which just comes for head impulse, test of skew, and nystagmus. So three components which we are supposed to look at. And now we also talk about HINTS plus, which takes into account balance and hearing as well. So what we are looking at here is the head impulse test, in which we do rapid head movement from side to side and looking for catch-up saccades in the eyes, and looking for skew deviation, which is basically vertical misalignment of the eyes, and looking at the type of nystagmus, whether it's a central type of nystagmus or a peripheral type. So helping differentiate this will help us know if this is likely to be a central or a peripheral type of vertigo. Apart from this, of course, neurological examination to look for any signs of predominantly brainstem involvement, which we call like slurring of speech, difficulty swallowing, any abnormal facial weakness, tongue weakness, imbalance when signs of ataxia, that is cerebellar involvement, loss of sensation, weakness, all of these are signs that is much more likely to be central rather than peripheral. Of course, all this differentiation needs to be applied in the correct clinical setting. So this is needed when we are talking about an acute onset vertigo. So when you talk about vertigo, that's why the history is first. When you talk about any case approach, you always say history and then examination. This is where the history becomes important because we need to establish what the actual syndrome is. We can have acute onset first attack of vertigo. We can have episodic vertigo. We can have triggered vertigo. We can have non-triggered spontaneous vertigo, or you can have chronic vertigo. So all this differentiation is very, very important, especially in the acute attack, the first attack of vertigo, because here's where your dangerous conditions such as stroke into the picture. So when we suspect stroke, this examination becomes very, very important because they have shown that this examination is better than an MRI if done within the first day of picking up a stroke. Even MRIs can miss 3 to 4% of strokes within the first day, whereas this clinical examination, if applied properly, has much better sensitivity and specificity to diagnose a stroke.
Yes, that is so new information, and that is actually even helpful, as you said, rightly said that in the initial assessment, it is very important. So now, at what point should a patient with vertigo be referred to an emergency room? And what are the red flags healthcare professionals should look out for?
So as I said, the first thing to look at is what is the syndrome. So when you have the syndrome from the history, which just needs a few minutes talking to the patient, is this an acute vestibular syndrome, which is what we call sudden onset symptoms which are persistent. If that is happening, that is called an acute vestibular syndrome. Any acute vestibular syndrome is a red flag and needs to be seen by a specialist. There's no questioning it. Of course, there are other things. You can have episodic, recurrent attacks of vertigo, which can happen. So if somebody is having multiple attacks of vertigo, then we call it as episodic vestibular syndrome, which can be triggered. Or we talk about somebody getting vertigo if they lie down, they turn over in bed. If you turn over, you get a few minutes of dizziness and vertigo. That is a classical BPPV. So these are not emergencies as such, and they can be seen initially, treated, and then sent if they're not improving. But the acute vestibular syndrome at any time has to be seen by the specialist because that is when the risk of a stroke is much, much higher. When you talk about red flags in the symptoms, apart from an acute vestibular syndrome, if you're having episodic, even in the episodic, if somebody has any of the symptoms which suggest a central nervous involvement, such as double vision, somebody is having difficulty swallowing, difficulty with speech, unable to use a limb, complaint of numbness, slurring of speech, all of these are signs that there might be involvement of the central nervous system, which are definite red flags for an urgent evaluation by the expert.
Okay, so such like whatever these things that you had rightly said. So these do they actually give you early signs, or they just go into the next step or the urgent basis care, like an emergency?
So if these red flags are seen, the patient needs to be seen in the emergency immediately and ideally examined by a neurologist, because what we need to, the first things first is making sure there is no central nervous system involvement, because you can have a stroke, you can have a demyelination, you can have a tumor in the posterior forehead conditions like this. All of these need to be evaluated urgently, and which is usually done by way of an emergency imaging, preferably an MRI, because a CT scan unfortunately does not pick up changes in the areas which can cause vertigo. So the MRI is the preferred imaging choice. And if they do not have these red flags, the patients can be sent to the OPD for further evaluation. In which case they get, which means that they might not need imaging on the same day, and the treatment by itself might not change immediately. So you can take our time and try to manage them on a day-to-day basis as the symptoms come.
Absolutely, that is true. Now, how should healthcare professional approach the differential diagnosis of a vertigo in a primary care setting?
So the differential diagnosis depends on the underlying syndrome. So when we talk about acute vestibular syndrome, there are two common diagnoses we think of. One is peripheral, one is central. So always we like to think, okay, what is the syndrome? And then is it peripheral or central? That's where we come from. So if it's an acute vestibular syndrome, the central is a stroke and peripheral is vestibular neuritis, both of which are emergencies. And if it comes to episodic vestibular syndromes, when they're spontaneous, we talk about central migraine, vestibular migraine cause, which is unrecognized most of the time. And you can also have very rare syndromes, such as Tullio phenomenon, separate mobile third window, superior semicephalic dehiscence, which are quite rare. And you can also have other conditions such as a Meniere's disease, which can present as spontaneous vertigo, but is usually associated with hearing loss, tinnitus, and other conditions. When it comes to triggered conditions, so the most common cause we all know is BPPV, which again is it's a peripheral cause of vertigo. Unfortunately, what happens with BPPV is that people get confused about the symptoms, but at 2 minutes taking the clear history from the patient tells us that it is episodic. And the patient can claim that I've been having vertigo from the morning. You talk to them, they'll know, oh yes, it comes in for 2 minutes and then goes away. And then turn my head, comes in for again 2 minutes and then goes away. And that is episodic, not a persistent vertigo since the morning. So again, that is an episodic vestibular syndrome, which is triggered by a specific posture. So when that is seen, it is very easy to diagnose PVP by history. And of course, confirmation is by positioning tests. We have the Dix-Hallpike test, we have the supine roll test. And when we pick that up, of course, the treatment is by canal repositioning maneuvers, which change based on what canal is involved. So the history is where your differential diagnosis usually starts from. And once we have the syndrome, of course, we say differentiate central and peripheral. Once that's done, we always have, we can have a short differential diagnosis. And looking at the most common causes, these are the ones we look at. Of course, there can always be rare ones. We can have positional vertigo due to a central tumor, which of course is very rare. And if we can't find signs on examination of a central cause, then they might need urgent imaging as well.
Yes, absolutely. I think that is why it is necessary to have a structured approach towards the patient from diagnosing to treatment options. Now, can you share with us some latest advancements in the pharmacological treatment of vertigo? And how should clinicians actually decide on what the appropriate therapy for their patients should be?
So, treatment of vertigo again depends a lot on the underlying etiology. What is prevalent in society is everybody with vertigo just gets vestibular sedatives, either in the form of beta-histone or mefloquine or cinerizine. All these drugs are just used randomly. Anybody who has vertigo symptoms, they just get prescribed medications. But of course, yes, they will work for a short time. But without understanding what the actual etiology is, it is very hard to say how long to treat them with the medications. I've seen patients who've been on beta-histone for years together just because they complained of dizziness and somebody started it and just never bothered to stop it. Unfortunately, many of these patients turned out to have not actual vertigo, but dizziness due to other causes like orthostatic hypotension and Parkinsonism, which is unfortunate because beta-histone can actually worsen Parkinsonism. So these are there needs to be judicial use of vestibular sedatives and medications in vertigo. For a stroke, unfortunately, the best medication is thrombolysis if they pick it up earlier. And beyond that, it is going to be rehabilitation and balance training. That's the best therapy. Vestibular sedatives on recovery of vertigo due to a stroke. When it comes to the other causes, vestibular neuritis, of course, responds very well to sedatives, but they also need steroids and other immunosuppressants, which can actually help the recovery. There are other conditions when you talk about Meniere's disease. Recognizing Meniere's is very important. Once we diagnose it, the therapy is, of course, beta immunosuppressant. Vestibular suppressants are useful. Along with, sometimes we have a lot of debate on which drug is the best choice. Drugs at all. Some people say use as many drugs as possible. So it's unfortunately there are no clear guidelines on what to do. Acetazolamide is one of the preferred drugs when it comes to Meniere's. For migraine, which, as I said, is a very, very common cause but under-recognized, the treatment is quite similar to migraine, and you just have to be a trial and error basis to try and avoid attack as much as we can. The most common cause of vertigo, which is BPPV, the benign positional paroxysmal vertigo, the best treatment is canal repositioning maneuvers to try to correct the imbalance and the position of the otoliths. However, there is a role for a short-term use of vestibular sedatives to help with the symptoms, but it should not be used for more than 1 or 2 weeks, the maximum. Longer-term use actually can be detrimental and impair the rehabilitation, which in turn can lead to chronic dizziness and conditions such as perceptual postural dizziness, which can be quite debilitating and very, very hard to treat as well.
Yeah, that is actually truly said, and I think some of the sedatives also have a long-term side effects as well. Does also one more question would be like, does it actually interrupt with any diseases like comorbidities? If you have, does the treatment affect the comorbidities, or does it depend on any comorbidity?
So, use of things such as cinnarizine and metclizine and of course beta histine has been known to worsen Parkinsonism, which is very unfortunate because we know that patients with Parkinsonism can complain of dizziness even though they might not have actual vertigo. However, what I have, this is my personal opinion, is that I have seen patients with Parkinsonism tend to have much higher chances of BPPV, probably due to their stiffness. It's as a trigger, there's a risk that they do tend to develop BPPV. So they start on beta histine and they just never stop, which is very, very unfortunate because it will interfere with the central compensation mechanisms and lead to actually worsening of their balance and posture, which is a very important part of Parkinsonism as well. So recognizing the underlying condition is very, very important, which is because it helps you decide on what drugs to use. We also have found that in long-term cinnarizine use can lead to the development of Parkinsonism-like features. So that is something we might have to keep in mind before prescribing drugs.
Yes, that can sometimes also be saddening and for patients as well as healthcare professionals to look into the right treatment. Now, how should clinicians handle cases where vertigo is accompanied by other neurological symptoms such as headaches or vision changes? Actually, what we were talking about.
Yeah, so we do, as I said, headache is a very important clue. Because when we get a headache with a dizziness, and especially if it is having recurrent episodes, the diagnosis we need to think about vestibular migraine, which is quite, it is not a dangerous condition, but it is slightly difficult to treat. Recognizing it is the first step, of course, and then you need to educate the patient about it and reassure them that yes, this can be treated just as you would treat a migraine. The unfortunate part is that we do not have high quality studies which will tell us that, oh, this is definitely going to help us, this is going to definitely help vestibular migraine, or this drug is the best choice. At best, what we have now is guidelines which say that treat them as you would treat any other type of migraine. This is what we do. We give them medications, we give them abortives, we give them prophylactic drugs, and we follow them up and see if they still have recurrent episodes. Of course, there are times when a headache especially if the headache is first time onset, and is significant and it's debilitating, we need to think of other conditions which can present with migraine as well. Present with headache and vertigo as well, such as suppose a bleed in the brain, or a demyelination, or a raised intracranial pressure. So those are conditions where you need to urgently do imaging to make sure that we are not missing such dangerous conditions.
Yes, that is a very important consideration, I feel. Now, could you share a case study that highlights a complex and unusual presentation of vertigo and what lessons were learned from it?
So I have a patient who had been treated for multiple years as possible Meniere's disease. So this lady had been on vestibular sedatives for I think 3 years. She came to me. The complaint was that she could not walk. She's still feeling unsteady all the time. She can't walk. When I re-evaluated her, there's absolutely nothing wrong with her vestibular system. And we know that Meniere's is an episodic illness. It is not a chronic illness. So it's an episodic vertigo. A patient should not be having consistent symptoms. So I had to so the difficult part was reassuring the patient that what she now had is what we call PPPD, phobic postural perceptual dizziness, which is a consequence of undertreatment or overtreatment during an acute attack of vertigo. So unfortunately, this patient had chronic dizziness, and this she needed to be taken off the vestibular sedatives, which was the hardest part because I had to convince her that they did not take the medicines anymore. And then yes, we did treat her, and she slowly got better. And as luck would have it, 1 month later, she had an episode of DPPV. So now she had two different types of vertigo occurring at the same time. So the treatment again I had to recalibrate the treatment because now she had to go on vestibular sedatives, even though I knew it would make her chronic dizziness worse. So we had to give a very short course and we used the repositioning maneuvers. The most important part I've noticed is such patients is reassuring the patient they should avoid fear at all costs, because that when fear or anxiety sets in during an acute attack of vertigo, there's a very high chance they can lead to chronic dizziness.
Yes, absolutely. And I think that was such a fascinating case, and it really underscores the importance of, thorough evaluation and what actually the patient is also facing. So before we wrap up, one last question from my end is like, how can healthcare professionals better educate their patients to manage vertigo symptoms and to avoid the triggers it causes?
Of course, if we have if we have identified the etiology, the best thing we can do is reassure the patients, especially with the most common cause such as DPPV. What I like to tell patients is that do not be afraid if you have an attack. It's not going to be life-threatening. It's just a symptom which looks very bad, but the actual etiology is quite benign, and we can treat it, and it's very easily treatable. So the worst thing that can happen is the patient can panic when they have an attack, and this, as I said, can lead to other complications such as chronic dizziness, which are much harder to treat. So the best thing I would say is, if you have an attack of vertigo, of course, if it's the first time, please come to the emergency. But if you're having this recurrently, and if you can pick up that, okay, I'm getting this only when I do this in a specific position, avoid doing the position for them. But of course, do meet the doctor so that he can make it better. And avoid anxiety at all costs, because anxiety is the biggest curse for treatment of vertigo.
Yeah, that is rightly said. And as we wrap today's episode, I would like to thank Dr. Sreenivas for sharing your expertise on such an important topic. I know that vertigo can be a challenging condition to manage, but with right insight like yours, healthcare professionals can better be equipped to help their patients. So thank you so much for sharing your insights, Doctor.
Thank you for the opportunity. It
And
was a quite nice interaction to have.
Yes, it was actually. And to our listeners, thank you for tuning into this episode of MedSynapse podcast series. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay aware and stay updated. Thank you.